Hello everybody, today we are going to talk about hypertrophic obstructive cardiomyopathy and aortic stenosis. I won't go into the physiology, the detail. It's not a lecture. It's just to touch some high yield points that might help you in your clinical practice as well as during the exam. This is the most favorite topic for the internal medicine as well as cardiology board as well as heart failure board as well, because there are so many high yield physiologically relevant mechanism that you need to know, and that makes it a very likable testing topic. So with that, we'll come to hypertrophic obstructive cardiomyopathy and aortic stenosis. I want you to look at picture 1 here. This is a diagram of hypertrophic obstructive cardiomyopathy. If you look at this septum here, it is thicker, and that's when we do an echo, we look at what's the thickness of the interventricular septum. There are a lot of variants where there can be a thickness of the anterior wall or there can be a thickness of the apical, but by far the most common is where you have this thickening of the interventricular septum that encroaches the LVOT. So the star here, this is your LVOT called left ventricular outflow tract, and with this thickness in the septum it kind of compromises the LVOT, and that's what causes the dynamic outflow obstruction, what we call like a hypertrophic obstructive cardiomyopathy. One thing you have to know is that there is nothing wrong with the valve. Both the mitral valve as well as the aortic valve are fine. It's just that there is a cardiomyopathy. In compared to that, if you look at picture 2 here, you have a normal left ventricular mass. With somebody who's got aortic stenosis, there could be concentric hypertrophy. If it is a long-standing aortic stenosis, patients can have heart failure and low EF as well. But in this example, we'll just keep it. There is a left ventricular wall thickness which is normal. But if you look at this valve here, it is all calcified stenotic. So the problem is with the valve. So again, in hypertrophic obstructive cardiomyopathy, as the name suggests, it's a cardiomyopathy, while in the aortic stenosis, the problem with the valve. This concept is important as we will go into the physiology. So with that, I want you to understand that the basic physiology is that things that make that LVOT obstruction worse will increase the murmur in HOCM. And the things that will allow more work for the left ventricle to push the blood against that calcified valve will increase the murmur. So the way I remember that is a stress. So anytime you have more stress in HOCM, it will decrease the murmur. Does not make sense when you say, well, why is that? If you have more stress on the ventricle, how would it cause the decrease in murmur? Again, it comes back to the physiology. So basically when I say is more stress, is when you have more stress, there is more stretch. So what happens is if the LV cavity in HOCM is under stress, there is more stretch on it, it is filling more, or if there is more afterload and the left ventricle has to kind of dilate to push that push that blood into the aorta, what will it do is basically it stretches the LVOT here. So the LVOT diameter will go up. So I just want you to grab this concept as we will talk about different murmurs, and then last but not the least, some of the graphs that we need to know about. So again, more stress on the heart, more stretching of the left ventricle muscles, more stretching of the LVOT, and the LVOT diameter will increase and the murmurs will go down. As compared to that, if you come to the aortic stenosis, there is more stress to the left ventricle, the murmur will go up, or you will have a louder murmur. That makes sense because if the left ventricle is ejecting more blood against a stenotic valve, there will be more turbulence, there will be more flow across the valve, and there will be increase in murmur. So again, more stress on the left ventricle in HOCM, decrease in murmur, more stress, on the left ventricle in aortic stenosis, the more the murmur. So with that, we come to the Valsalva maneuver. So we know that in Valsalva maneuver, you take a deep breath, you hold it, blow against the closed glottis, and then you increase intrathoracic pressure. With that, you also decrease your venous return or the preload. And what it will do with the Valsalva, is that there is decreased preload. With the decreased preload, there will be less blood coming to the left ventricle. So the left ventricular volume will go down. And as I said, less stress on the left ventricle, the murmur will go down. So in aortic stenosis, with the Valsalva, decreased venous return, decreased LV cavity filling, the left ventricle has to eject less blood, so the murmur will go down. As compared to we come back to the HOCM. As we said, in HOCM, you really want to stretch the left ventricle cavity to kind of stretch the LVOT. So if you have Valsalva, there is decreased venous return, there is decreased left ventricular filling, the cavity shrinks, and then the obstruction becomes worse. So in this case, the murmur will go up. Similarly for the hand grip, so if you ask the patient to do a hand grip, so basically what you are doing in these patients is decreasing the venous return, but also increasing the afterload. So there is more adrenaline, there is more peripheral vascular resistance. So in aortic stenosis, as I said, again, the heart has to kind of push the blood against that afterload. So in patients, if you ask them to do a hand grip, either their murmur will go up slightly or may about remain the same. But interestingly, as I said, when you do the hand grip, increase the adrenaline, the peripheral vascular resistance, basically increasing the afterload here, will cause the left ventricle to kind of work a little more, and it kind of stretches a little bit, and then that's when you will see that the murmur of the HOCM will go down. Standing is the same thing here. When you stand up, you pull more blood into the legs. The left ventricular is happy because the afterload is going down. So the murmur in the aortic stenosis will go down. But as I said, in HOCM, if you decrease the afterload, you're asking the left ventricular cavity to kind of eject more blood into the aorta, and as it does, it causes more contraction, more compromise of the LVOT, and then the murmur will go up. So this is kind of the basic concepts of what's happening behind aortic stenosis and the HOCM. On the board, they like to test these. If you know the physiology, you will easily get it. One of the cheat sheet, or one thing that I would like you to understand here, and that's going to be the board pearl, is the bifid pulse, bifid carotid pulse. So if you see a patient or a question on the board where they are giving you all these physiology and the murmurs, and you see this word, the bifid carotid pulse, most of the time, about 80-90% of the time, they are just talking about the HOCM. So some of the things that you need to know at the board, like to use these words for a specific condition, so that will guide you as well. Another thing that can happen in hypertrophic obstructive cardiomyopathy is what we call like a SAM. It's called systolic anterior motion of the mitral leaflet. Basically what's happening is, as I said, the LVOT is smaller because of the hypertrophied septum, and if you have this mitral valve here, when there is a dynamic outflow obstruction, this mitral valve leaflet might come all the way against the interventricular septum and causes an obstruction, and we call it systolic anterior motion of the mitral leaflet, and causing a dynamic obstruction. So in these patients, we try to avoid inotropes. We try to give them beta blockers to slow their heart rate down. And these patients might need surgery or septal resection. With that, we come to another important concept that they will check you. And for that, I want you to look at picture 3 and picture 4 here. And again, as I said, this graph will appear on the board as I have drawn here. And if you know the concept and if you have seen it one time, you will easily get the question right. And the fancy name for that is Brockenbrough Morrow Braunwald sign. So there were 3 doctors, Brockenbrough, Morrow, and Braunwald, who described this phenomena. And it's not something new. It was done in the Cath lab maybe 3 or 4 decades ago, and you can find it in a very old New England Journal article where they described it as a Brockenbrough Morrow Braunwald sign. So basically what you are looking here is EKG. So this way is your EKG. There is a normal beat. There is a normal beat. Then you have a PVC, and then you have what we call like a compensatory pause. I'll just write it as CP, or the compensatory pause, where everything is resetting. And then what I want you to look at, this is a blue waveform. These are your LV pressures. So LV systolic, LV and diastolic. So it's LV EDP. So this is your waveform for the LV. And this red is your AO waveform. So I'll just label this blue as LV waveform. And then you have this red, which is kind of a AO waveform. So this is your AO waveform, the red. And as we talked about, there is an obstruction. So this is what your gradient between the AO and the LV. So with that, we come first to this picture 4 here, where you have this aortic stenosis, where you have fixed obstruction. So as you know these waveforms, now this is your gradient, the pressure difference between the AO and the LV. The LV pressure will be high because there is an obstruction in the aortic valve. So the LV pressure has to go up to kind of push open the valve. And then this is your AO systolic pressure. And the difference between them is your gradient, as in this red arrow. So now again you come to what we call like a PVC. So PVC usually happens before a normal beat. The LV is not filled well, so you see that LV pressure goes down, that because the LV is not contracting rhythmically, and then the AO pressure will go down. There will be a compensatory pause where the LV will fill up, and the next time when on the next beat, next normal beat, since the LV cavity is stretched, there is more filling. We know from the Frank-Starling law that the more stretching, there will be more contraction with that. So what will happen is the LV pressure will go up. So since the LV pressure will go up, it will open the valve and pump more blood into the aorta. So the aortic pressure will also be up. So aortic systolic pressure will be up. So what basically it shows is the LV pressure will go up, the AO pressure will go up again at the same time. So this gradient will stay the same. And this is a very important concept. And this is what they're going to be testing you on the board. So again, PVC, compensatory pause, the next beat will have more vigorous contraction. The LV systolic pressure will go up. So will be the aortic systolic pressure, with the gradient or the difference between the LV systolic and the aortic systolic remaining the same as compared to on this beat 1 and 2. Let's come back to picture 3 here, and we look at this Brockenbrough-Morrow Braunwald sign. So here again you have beat 1, beat 2, you have this gradient, nice gradient between the LV systolic and the AO systolic pressures. You have this PVC, this is beat 3. Since the PVC occurs before its normal time and is not a rhythmic contraction, so the LV pressure will go down, and there won't be a lot of blood going into the LVOT or the aorta, so the AO systolic pressure will go down as well. Now what's interesting is we have this compensatory pause. After this compensatory pause, you will have more filling of the left ventricle, and this time what will happen is that the LV will contract more. So as the LV causes more contraction, the more contraction causes more obstruction, and that's why we call it hypertrophic obstructive cardiomyopathy or dynamic obstruction. So as the LV contracts more, it compromises the LVOT diameter. So what will happen is that your AO systolic pressure will go down because there will be more obstruction. LV pressure will keep rising. As the LV pressure goes up, the LVOT will get more compromised. There might be systolic anterior motion of the mitral leaflet, causes more compromise of filling or the dumping of blood in the aorta. So what will happen is that the aortic systolic pressure will go down. So in this case, as compared to aortic stenosis, LV systolic pressure will go up significantly, and then the aortic systolic pressure will go down. Compare that with the aortic stenosis, where LV pressure goes up, the aortic pressure goes up as well, and the gradient between them stays the same. Here, if you look at this red line here, there will be a remarkable difference between the LV systolic and aortic systolic. And this is your Brocken-Morrow-Braunwald sign, and I'm pretty sure they will have that on the cardiology board in one of the questions. Very easy, straightforward. They will just show this graph and want you to kind of understand what's going on with these waveforms. With that, we'll stop. You all have a very good day. Thank you.